Hello, everybody, and welcome back. This is the last session in the summit, and here we're going to be talking about the role of technology. We're going to find out what impact it might have on cardiovascular patients, their care, their routine monitoring, screening, etc. I have a fantastic panel who I'm going to introduce to you in a minute, who help us explore the implications of technology in this area. But before we do, we want to ask you a question. I'm going to launch a poll. And you'll find the poll on the screen. If you looked where you could see the Q&A, and that's in the bottom of your menu underneath the video player. You'll see it says Q&A, and then next to it on the right, it says poll. And the question we're asking you is, do you think that technology should be a greater part of cardiovascular care? And we've given you three options to answer. That's yes, no, or maybe. We're going to look at the results of this poll in a minute. Now I'm going to look again at the end of the session, and you can change your vote. So we'll hear from the different experts about how technology is being used, and you can feel free to change it later if you want to. But let me now introduce to you the panel we've got who are going to help us get to grips with some of these big issues. So let me introduce to you Professor Martin Cowie, the Professor of Cardiology at King's College London, the Chair of the ESC, that's the European Society of Cardiologists, Digital Health Committee. We have Dr. Jean-Luc Eisler, who is the CEO of the World Heart Federation. We have Dr. Ratna Devi, the chair of the International Alliance of Patient Organizations, the CEO and co-founder of Dakshama A Health and Education. And we have Dr. Petra Wilson, the CEO of Health Connect Partners. So we have a fantastic panel who've really got expertise in this area. But before we get into that, let me have a look at the results of the poll that we asked you. Now, this is interesting. Because clearly the audience feels that technology should be a greater part of cardiovascular care. We had a couple of people said, maybe. We'll have a look at this poll again towards the end to see where people feel that technology should or could, or perhaps couldn't, play a role in cardiovascular care. Let me start by asking Professor Cowie a question. We are living through, again, an incredibly intense period of COVID-19, where Europe is yet again the epicenter of global infections. And it had a massive impact on our health systems, on routine care, monitoring appointments, surgeries were cancelled, and patients were even frightened to go to healthcare settings. Martin, can you help us understand specifically the impacts on cardiovascular?
Well, indeed, the whole world has been turned around, hasn't it? It's unrecognizable from before. And all of us, including healthcare professionals, looking at those scary pictures from Wuhan and from New York and from Delhi with all the infection. And I think you've highlighted already some of the key points. So a lot of people scared to come to healthcare facilities, wanting to avoid that, but still the need for diagnosis, for reassurance, for monitoring, and for discussion about healthcare issues. So how do you deliver that? At the same time, the workforce all redeployed to look after very sick patients with COVID, and complete change in their roles. So how do you match what's really wanted with what was available at a time when human-to-human interaction was very limited? So thank goodness we had digital tools. Can you imagine this happening 40 years ago? It would have been so difficult. So almost overnight, and we use the word tech acceleration, 10 years of change in just a few months, where across the world, a lot less face-to-face contact, a lot more video like today, and also telephone contact as well. Challenging at times. How can you have a difficult conversation with somebody you've never met just over the telephone? It's hugely difficult and suboptimal. But for many interactions, of course, we now know that they are actually probably better with a video call. And everybody's now much more familiar with that. It's much more convenient. If you know the doctor or nurse already, you might very well quite enjoy the convenience of a quick chat with them to catch up on what's happening. So a real change, and how it will all land, I do not know. When it will land, I do not know, but we will end up with a different scenario of a blend of different approaches, hopefully different tools for different points, underpinning the need for constant interaction between patients and the healthcare advisors.
Just as you said, there's been this enormous uptake in use of digital tools, and a lot of it's being used in remote monitoring. And now that has become central to patient care, remote monitoring, consultation, what does this mean about the way we make decisions on treatment or care? Because as you say, it's hard to do the difficult, complex, and perhaps, ethically difficult conversations through that. So to what extent will that be just for the background, but actually the more important, more complex stuff will have to happen face to face?
Yes, it's interesting. And I'm sure the panel discussed this about the role of technology here. So in a way, 5 years ago, it was about how could you monitor your patients with lots of technology, streaming data back to you, a tsunami of data, people called it. How could you make sense of it? How do you just end up being swamped by all of this information? How can you get this signal from the noise, in other words? And a lot of work going to try and support that and changing the way we interact with patients. I think the vision for the future is slightly different from that, though. And this is how can people living with chronic conditions like cardiovascular disease, like atrial fibrillation, like heart failure, coronary disease, how can they use the right technology at the right time to support them to live better lives, more closely managed, better outcomes, better experience of care? And how does that interact with the healthcare world? Maybe you don't need to see them very often. Maybe the technology can support you and only drag you into the healthcare system when you need to, but you have to be able to do that at the right time. Lots of things going on in this space, lots of creativity, hopefully more co-design. So it's not just technology being designed by boffins in a back room and thrown at the wall, hoping it will stick, but much more a concept of what's the problem? What are our solutions? Let's design it together and let's try it. And don't be afraid of failure. Plan A may not work. You may have to tweak it to be plan B. You need to learn this process. And I really do hope, it's my final comment here, is that the creativity and innovation that COVID forced us to have, let's hope that stays after COVID becomes more endemic, and that we actually think there are different ways to do things. What do we want? What does the future look like? And let's co-design that together.
Thanks, Martin. And I'm just struck by something that when maybe sort of 5 or 10 years ago, when I was involved in conversations about the use of technology in healthcare, there was a lot of fear that the technology might replace that human interaction, the face-to-face contact. And what you're talking about is quite different. It's how that human connection is maintained, but it's supported by tools that are jointly developed, that are personalized, etc. So it sounds to me like the worst fear of being replaced by a robot, impersonal face is not being realized, but they are more integrated into this continuum of care. Is that right?
Yes, I think we don't hear the word disruption now, where the old is all just completely swept away and we're in a new digital robotic era. That's not the word that's used. It's about support. It's about transformation. It's about the right tool for the right time for individuals. And I think artificial intelligence is often an example that's given, that it will sweep away all human activity and it will all be controlled by machine learning. That's not going to happen. But I do know that doctors that resist machine learning and automation will be replaced by doctors that use it as a tool to improve their decision making and to allow them to free up the time to do the human factors, the empathy, the discussions, the learning what the values of the patient are and how to merge what the options are with what they want. So let's use these tools to add to human value, not subtract from it. 1 + 1 should equal 3 here, rather than 1 + 1 = 0, as so often it has done in the past.
Thanks, Martin. Jean-Luc, if I could bring you in at this point, we've just heard that digital tools can give cardiovascular patients a new role in managing their care. But what do patients need to understand about their own health data and how to use it? Because the empowerment starts with a basic sense of literacy and an ability to read and interpret your data.
Thank you, Tasmin. Maybe let me start with an analogy. If you're about my age, I used to save money when I was a child, and I had a kind of pig where I was putting my coins in it. And when the pig was full, I was going to the bank. The guy would have a key, open it, count the money, and he would put me on an account. And so I was saving money, but I never know how much was in the pig And to get a sense how much I've saved, I have to ask the person, go to the office, how much is on my bank account. And I think in the health data, we're a bit in the same situation. And there's an opportunity for transition for 2 reasons, or 3 reasons. The first one is that in cardiovascular health, a lot of measurements can be done through non-invasive technologies, whether it's hypertension, whether it's ECG. You can do a lot, you can monitor a lot of your health, cardiovascular health, through these non-invasive technologies. And that's different than maybe gastroenterology, where you want to be more invasive. So there's a possibility for cardiovascular health to be at the front. The second is this concept of patient-centered healthcare system. We have been discussing for years that the patient should be at the center through different ways, but it's also been an issue. And I think here there's an opportunity, first because you start generating your data yourself with devices, just Apple Watch or more sophisticated medical ones. But you generate the data. The same I was putting my coins in the pig. You generate your data where previously that was the doctors or the healthcare system which was generating data. And the second is that you through the connection with the healthcare records, it's not only the doctor who has access to the data, it can be shared with other healthcare providers, but also with yourself. So suddenly the patient is in a position where he's generating the data, part of the data, and he can have access to the data. That's a totally different vision of the healthcare system we had maybe 20 years ago. Now that includes, when you're in this position, of course, that there's an element of trust. You need to trust the system, the healthcare system, the providers, about confidentiality, but also about how the data are stored, where they are. But there is a great opportunity to promote prevention. Because you have the data, you control the data, you know where you are. In terms of prevention, prior prevention or prevention of disease, that's where we see a unique opportunity for the patients to get more involved in managing his healthcare situation through data.
Thanks. I was going to say, I mean, we perhaps need to talk about the elephant in the room, which is the issue of inequality. We already know that in cardiovascular care, inequalities has a huge impact in both the risks and the outcomes. Should we expect all patients to become active using technology? We just heard that doctors who use AI will continue, and doctors who don't, or who don't use technology, will gradually become obsolete. But patients can't become obsolete. What if they don't want to or can't engage with technology? Will they be get the second quality care? They won't have access to all these things. Can we open up this question of inequality for a moment?
Yeah, thank you very much. I think it's a very important question. And at the World Heart Federation, because we're a world organization, we're very sensitive to inequalities, access to care. It's not only about low and middle income countries, it's underserved areas. And we know that in Europe, in the United States, you have part of the population which is really underserved. So maybe the first aspect in this inequity or equity is the access to internet. 50% of the world population has poor or no access to internet right now. There is this concept of access to internet should be a fundamental human right. So that's the first aspect. And I'm not too worried about this one because that's probably the easiest to, which is will move forward naturally. I mean, we've moved from land phone lines to mobiles. And I'm in Kenya here, everybody has a mobile. Maybe they don't have the full 4G, 5G, but they have a mobile. So this will move. The more tricky one is the access. Martin was mentioning the fact that the doctors will not be replaced by robots. So we know we still need doctors, but it's how you access these doctors, especially in remote areas. I mean, here in Kenya, you have 50 cardiologists for 50 million inhabitants. Okay. You can train more cardiologists, but it's not going to fix the problem in the next 5 years. And there's the interesting cases, which were actually, I'm a congress here of the Continuum Society, which were presented where in rural area, they're using mobile technologies and community health workers who are trained to use the system to do some basic measurements that can be even echocardiography, but the data are analyzed in the in the evening by a trained cardiologist. That can be in Kenya, but can be somewhere else. So that's a way to reduce this access to inequalities. But at the end, I think the question you find is, are people willing to move into this new technology? And here you face social determinant of health, education, access to literacy. And that's where I think patient organization can play a major role through this community that has been created post-COVID or through the COVID, this group of patients, this group of action, this group of reflections, which have been created because of the lack of opportunity for physical interactions. I think that's where I see patient groups playing a role in reducing this inequality.
Thank you, Jean-Luc. Ratna, let me bring you in now at this point, because we heard at the beginning how you could call COVID-19 not just a pandemic, but a tech accelerator, because it has really triggered this enormous shift to go online in the use of digital and technology tools. But obviously there were different barriers and challenges to the use of tech across the world. Can you tell us what, for the patients that you deal with around the world, what were some of these barriers to the use of digital tools?
Thank you, Tamsin. And I will sort of split this into two parts: the technology part, which creates the barriers, and then the human part, which or the systemic part, which creates the barriers. And as Professor Jean mentioned, availability of internet and devices. We do know that mobile penetration is high in most parts of the world, but then sometimes you do not have electricity, you do not have broadband. So you do have the internet connectivity, but you don't have enough broadband or the bandwidth to be able to use an app, especially for a video call. So maybe a voice call is possible, but video calls, as we know from our Zoom experiences in the last few months, there are technology challenges everywhere. So that's part of it. Language is a big, problem, because usually most of these global apps are in English, and for populations that have native languages, it's sometimes hard to communicate on a technology platform. So how do you make it easily understandable and that communication is not lost because of language barriers? Then you have age. So very senior citizens or young children, you cannot possibly use these apps. Also vulnerable populations possibly cannot use this. So if you are visually challenged, or if you have a problem, some other problem in using technology or a mobile device or any device for that matter, it becomes a problem. And then of course, as was mentioned earlier, the literacy part of it. And you might be able to do basic stuff, but most apps need you to enter some data, so your age, your profession, etc. And if you're not literate enough to be able to put that data properly, then there is a challenge. Then there is this systemic challenge. And I'm speaking from the experience of our country, where even in the physical world, when patients go to doctors, the system is very fragmented. And we do know that cardiovascular doesn't occur in a straitjacketed silo. There are multimorbidities. And if patients have to go to different specialties, then it's a problem when you're doing, virtual kind of a consult, because you see one doctor. So you have to have different appointments for different specialties. And the same person is going from one app to another, or one hospital to another. And sometimes these apps don't talk to each other. So the patient has to literally have multiple apps on the mobile, one for diagnostics, another for the consult with the doctor, the third for a prescription refill. And that could be extremely challenging for people who are not very comfortable using mobile phones. And then as was mentioned earlier by Professor Cowie, things like hypertension and other non-emergency, issues can be managed by technology. But if you're having a heart attack, it's so time sensitive. The patient will not be looking for an app to see which hospital to go to, and has to have access to the nearest hospital where they can rush the person. And if the person having the heart attack is not able to use the mobile, there has to be somebody in the home who is able to use that app and is able to book an appointment or alert the hospital on their behalf. And that sometimes is not possible. Not everybody in the house has access, even though we are saying that mobile mobile access is there, and almost everybody has independent mobile phones. Not everyone uses it to the same extent as the person who is most literate in the house. So how do you then train the family members to be able to manage, especially for cardiovascular events that sometimes are extremely time sensitive? And then we talked about the care continuum pathway for people with severe heart failure who need palliative care and other services that actually need a human interface cannot be managed by digital, however advanced we might be. It does need a personal touch. And then we also talked about trust. So when you go to a doctor, a lot about the patient's comfort is how you interact with the doctor. And that's a face-to-face communication that happens. It's very hard to get that personal touch on a digital platform. So maybe the first visit will always have to be with the doctor in person in a clinic or a hospital. But for non-emergency follow-up or routine follow-ups or long-term monitoring, we can use digital as an enabler.
Thank you, Ratna. Let me bring in Petra at this point, because we're going to explore now how digital tools are affecting and changing the relationship between a patient, the clinician, and their health systems. So how has this changing role of the patient adapted with the use of technical digital tools, and what challenges does this present in these power dynamics between the patient, the clinician, and the system?
Thank you, Tamsin. Many of the things that I could talk about have already been mentioned by other people, so I am going to refer back to a few of the things mentioned by other people. But I think to come to your question about how is it changing the relationship between the healthcare professional and the patient, I think one of the biggest issues that it's done is it's changing the locus of care. The locus of care is no longer necessarily on a healthcare professional's turf, if you like. You don't necessarily have to see a healthcare professional in their clinic or at their premises. And that has a big impact because it takes away at least some of what is known as the white coat tension. You're seeing a patient in an environment where they are able to be more at home, more at care, because they are at home, or possibly they're out and about or they're in their workplace. The flexibility that this is creating is very positive, and it can really help patients because, as I said, it can take away some of that stress and tension. It takes away some of the practical challenges of actually getting to a hospital. If you live in a rural area and it's a long way to see a healthcare professional, that can overcome issues. If you have poor mobility, either because you don't have motorized transport or you have poor physical mobility, it can help overcome some of those issues. And I think to build on some of the things that Dr. Debbie said, it also helps expand the circle and the power of the informal carer, the family member, the adult child, or actually, as we've seen in some dimensions, also the grandchild, who can actually be a really important vector of information into the care environment. So I think that flexibility issue is something that is really changing the dynamic. I think one of the other issues is, and it's also been alluded to by other people, I think Jean-Luc, you mentioned it also, there is this, the fact that there is a longer continuum of care that we are able to collect, we are able to monitor long-term much more easily. It's not necessarily based on a cumbersome device that a patient wears for 24 hours, but it can be real long-term monitoring. And that continuity of care can allow us to have a much more real picture of what is going on for a patient. It can also begin to identify things like stresses and stress points in a patient's life, where we may then come in with non-pharmaceutical solutions, stress management solutions to help them overcome some of the issues. That continuity of care and that flexibility of providing care where a person is allows us to collect much larger volumes of data. Jean-Luc, to come to your point, that piggy bank is much more full now because it's all sorts of data. It isn't just the data that you're going to create in a specific healthcare setting. It's all sorts of data that can be brought into the environment. Patient-reported outcomes can be much more easily integrated into care, allowing for a much more personalized element of care. However, everything that I've said just now is a slightly rosy picture. This all suggests that patients can easily access the devices at home, that there is a proper reimbursement mechanism for those devices in their home, that they have the intellectual capacity to deal with them, that they have the manual dexterity. Sometimes apps are actually very hard to deal with if you have limited sight or arthritis. There are all sorts of ideals that need to be met to actually make that flexibility, that continuity of care, that wealth of personalized capacity for personalization to actually make that real. And I think there are some of those challenges that we really still have to overcome, because at the moment, an awful lot we're talking about is within the realm of a few, those who can afford it, those who have the time, those who have the support, those who have the dexterity, those who have. And I think we really, really need to be careful that as we move forward to integrate more of these solutions, we don't leave people behind. Having said that, it is so important to involve more and more of these tools, because one of the scarcest resources we have in healthcare is human resources. We don't have enough clinicians to go around. With intelligent, thoughtful, and supported use of this technology, we really can extend the capacity of the healthcare professional. And I want to very briefly borrow a phrase and share with you a phrase that was developed in Denmark many years ago when they first started talking about the power of technology. And they said, what we must remember is that it has to be cool technology to extend warm hands. Cool as in easy to use, accessible, something we want to use, but its real power is to extend the capacity of the warm hands of the human interaction. So that's a little bit of what I think it can do, but there's also a few challenges in there.
Thank you for that, Petra, because as you say, there's huge opportunity, but we have enormous differences on who has access to it, the extent to which it's used, and whether people can actually take advantage of that. I'm going to start bringing in some of the questions that we've received from the audience, because we've got a very lively Q&A section, which I encourage you to have a look at. And I think there's going to be a question that I'm going to come to you, Jean-Luc. Perhaps you could answer this one. Somebody says, there seems to be a large resistance from physicians for allowing patients to directly receive data, such as detailed information from implanted pacemakers or defibrillators, rather than an external app they can manage. What actions do you recommend for changing this line of thought in order to give patients access to the data that would allow them to have better self-care than they get today? So this is a question about, pushing the barriers further with physicians, and particularly, again, we weren't talking about general basic health data they can do with their own mobile phone, but with the high tech, the implanted, and the other areas, which are very much at the moment the domain of healthcare professionals. Jean-Luc.
I think I would split, let's say, developed countries and underdeveloped countries. But let's talk about developed countries where the data is there. We have seen with COVID that at least last year there was 10 papers published every day, new data coming out, regression curve, statistician analysis, and even the professionals were lost, had difficulty to digest all this data. So I think we have to admit that having access to raw data or basic data requires some kind of training or some kind of education. That's why doctors study so much time. So I'm not sure that pushing all the data that even doctors cannot read or artificial intelligence computers have difficulty to analyze will help the patient to take care of his own health. But the same that when you're diagnosed with diabetes or hypertension, you have a kind of briefing of what to do, how to deal. I think the way forward is probably to have a kind of digested set of information so that you can understand what's going on. And I think the interest of digital health is you can understand not only when you go to your doctor, but almost in real time. But this information is to be provided in a way which is accessible to the patient, especially we're talking about inequity. That's really where the inequity can be the highest, in a way which is accessible, digestible, and implementable. Because at the end, what you want is the patient to take the right action. If he cannot access his doctor immediately, is what should I do? That's where the threshold for me is the data that I give that the patient receives will help him to take the right decision at the right time, even if it's a call your doctor.
Thank you. Radno, do you want to come in on this from the perspective of the patient organizations?
Yeah, I would say, it's more than what data gets to the patient. It is the question of who owns that data. Right now, the hospitals or the healthcare, providers own the data. The patient has no real ownership on it because they can't decide whether they want to, stop sharing that data, for example. So as patient organizations, most, of us ask, who is really owning this kind of data? And it's not just about the treatment data. If you are part of a clinical trial or if you are doing something else, really does the patient own that data and have that kind of independence to take a decision who he or she can share that data with. We do know that many countries have this regulation that all data belongs to the country and they can use it for creating patient registries or for further research or for epidemiological studies, etc. But we have seen now from, Facebook and others where you do have ownership to your data and you can say, no, I don't want to use this further. I can download it and I can wipe it off. Do we have that kind of freedom when it comes to health data? And can we really do it without harming ourselves? I think that's the solution that we should look for, that we have reasonable control on our health data and we are able to use it the way we wish to and go to the doctors or the healthcare providers or the health systems that we wish to go to.
Petra, can I bring you in on this topic? Because I know this is an area of real expertise for you. We're talking now about very complex data, very sensitive data. It's data possibly even generated by an app or a device or something that's physically implanted in us. But it's also information and data that, can't be, it's not like you can look at it and read it yourself. It needs interpretation. It might need to be taken in a context. How do we untangle some of these power issues about legal access, usability, reliability, and responsibility?
Thank you very much. There are lots of words in there: reliability, responsibility. Dr. Devi, you talked about the word ownership, and I really understand where you're coming from. We want patients to be empowered to access their data, to be able to share their data, to be able to have an active say in what happens to information about them. But the label ownership, I think, is actually counterproductive here, because ownership is a very definite legal construct. And central to the idea of ownership is the idea that you can give ownership to somebody else. For any of us who have children, one of the first things we teach children is once you've given something to somebody, you can't take it back. You've given it, you've given it. And that's not like that with our health data, because our health data, we want to share it for somebody to use it to treat us or to treat others. But that doesn't mean that they have now an exclusive right to it. So the ownership concept, I think, is very difficult. I think the other thing that's really difficult is disentangling with health data which part of health data actually pertains to an individual patient and how much of it is actually a co-production between the patient, the physician, and other people around them. Because, I mean, if we take, for example, I'm more familiar with diabetes. If we take the example of diabetes, I have an HbA1c value running around in my blood right now. I could own that, but it's of very little value to me until a physician and a device like a blood glucometer has interpreted that data and given me something that I can act on and I can use. So my suggestion would be that what's really important here is to really raise awareness of the importance of empowering patients to know what data is held about them, empowering patients to give permission to others to use that data or to withhold that permission, but to steer away from terms like ownership, because I think they're emotive and they can lead us down a rabbit hole that then is very hard to manage. So I hope that's helpful. And it's not a criticism, because I definitely understand where you're coming from. I would just urge caution in using that particular word. Thank you, Tamsin.
Thank you. Let's now move on to the most upvoted question that we have from our audience. And then, Professor Cowie, perhaps I could start with you to pick this up on, because we're being asked, what do the panel think are the most exciting possibilities for the medtech human interface in the next 5 years? So what can we've heard a little bit about what's happened and how COVID massively accelerated the use of sometimes quite basic tools. But what's the exciting cutting edge? What can we look forward to that you can see coming down the lines?
Well, the European Society of Cardiology just had its digital summit a few weeks ago, and actually the kind of summary of that is available online if anybody wants to watch it. So we selected the best of the best from the whole kind of cutting edge of digital. And some of it's super exciting, robotic surgery, where the surgeon is miles away from the patient, obviously. And if that's safe, then that's super exciting for many parts of the world. We also have virtual reality to help people cope with procedures. So you don't need so much analgesia if you have a virtual reality goggles on and you're looking at a different world and distracts you from the procedure being done. That's very exciting. And I think also, as we navigate the space of wearables and other type technology, how can we support people? And I think type 1 diabetes is a poster child of this. It's really transformational having a glucose monitor, having an app, having an insulin pump all connected. You forget about this, it happens automatically, and you would never think of involving the healthcare system. So can we find a model like that that works for other conditions? And as you hinted at earlier, Tamsin, most of us, as we get older, we don't just have one problem, we have several problems. So it's kind of, can we match what our modern issues are with technology to support us, so we can forget about our health issues. We get on with our daily lives. We go to our grandchildren's graduation. We plan our next holiday. We go to the theatre. We do whatever we want to do. And the healthcare is kind of taken care of with different technologies. So I'm not an absolute evangelist for digital. I think it has its place, but it's the whole concept that let's take the best of technology, demonstrate its value, use it where it has value, and don't use it when it doesn't. Just because it's new and flashy doesn't make it good. But where it does add value, let's really fine-tune it and use it for benefit. So, sorry, it's a rather vague answer, but there are so many things that are super exciting, as the young ones say.
Okay. Jean-Luc, let me bring you in on this as well, because what's interesting here is we've spoken a little bit about how technology at its best enhances the relationship between the patient and their health service, and it allows the healthcare to sort of run in the background while the patient has more power over what we're talking about. Let me explore, how can patients have a greater role in developing technology tools that they could use? So this isn't where somebody's designed an app or a medical device that's then used and proposed to patients, but where patients actually have a role in saying, these are the challenges I have in everyday life, and I'd like a solution to help me live my life.
Yeah, it's an interesting question, because again, it's what is the role of the patients in implementing these solutions, in developing solutions to improve healthcare systems. And it's shifting from the system where the healthcare providers, professionals, were the ones who decide. I think there's two roles I would see for the patient groups, which are maybe more advocacy role than technical roles. The first one is at the community level. We have these groups, whether they're virtual or just on WhatsApp, where people can share experience, discuss things. I think that's really a place where patient groups can help The same, you rate a hotel, a restaurant. Give their feedback, and the feedback can be integrated directly to improve the performance of the system, whether it's I prefer this app or I prefer this system. So far it was imposed by the healthcare systems. You use this drug, take it, and that's it. Now with the apps, you have a way where you can decide, select, and give feedback in real time. So that's probably the one level. The second level will be higher level policymakers, making sure that what we discussed about access to data, or call it as you wish, that the patient groups are involved in this discussion. And it's not only a top-down approach, but they are, again, it's not technicality, it's my rights, the access to healthcare system, and making sure that these tools are considered by the policymakers in the right way for the benefit of the patients.
Okay, thank you. Radna, can I bring you in on this issue on, how patients can have a greater say in the development of technology tools, whether it's identifying what needs need to be met or how they should be used, the cultural relevance, the appropriateness of this. How do you see patients taking more of a leadership role?
Thank you, Tamsin. And it's already happening in the tech world. You see more and more of the developers of these apps or the technology tools that we are talking about actually interacting with patients even before they start developing them, to understand what the patients want and what is it that they would ask for if a solution is going to be developed. So it's already happening in several areas, but there is still a lot of work that can be done in this particular area. Again, the prevention part of it, I think the patient groups can play a very large role. Technology can be used to communicate messages for lifestyle changes, regular follow-ups, and patient groups can do this very well because they have their membership and they can interact on a day-to-day basis based upon who their frontline workers are or who their expert patients are who are interacting with their membership. The second part of it, and a very large part of it that has actually happened during the COVID-19 area is counseling. The mental health issues and especially dealing with people who are having a hard time managing their condition, how can patient groups use technology and very simple apps and platforms to be able to reach out and comfort people who are having a hard time managing their condition. A lot of patient groups have also been able to add value in terms of emergency care and crisis response, because when the system could not respond, whether it was transport arrangement or connecting to a doctor or a frontline healthcare worker, patient groups have done a lot to be able to contribute to that particular area. And as Professor Jean-Luc said, the advocacy part of it is huge. And we do know that as the technology is advancing at a very rapid pace, the payment mechanisms and the reimbursement mechanisms have really not caught up in many parts of the world. And I think patient groups can play a very large role in advocating for that part of it.
Thank you. I'm going to pick up now on our second most highly voted question from the audience. And Petra, I'm going to ask you if you could make some comments on this, because it's highlighting the challenge of bias. And the fact that, the question says it's been reported recently that some medical devices, such as pulse oximeters, are not able to read results accurately on darker skin tones. How can medical devices that use this technology be future-proofed at the design and testing stages to reduce this bias? Now, that's the question from the audience. And we already know that we have existing biases in data sets. In cardiovascular care, again, the evidence is clear that women are underdiagnosed and undertreated. So we have these biases in our system. And I suppose one of the concerns here is that the great danger of applying and developing technology tools is it is using these data sets that where some communities are invisible, their needs are invisible. So how do we make sure that when we move and start implementing technology, that the diversity and the breadth of the patient population is taken into account?
I wish I could wave a magic wand and provide a solution to that problem. I'm not usually the first to say that European legislation holds one of the keys to the solution, but I think actually the draft Artificial Intelligence Act, which is currently in the process of negotiation, is a potential to address this because it has very firmly embedded in it a whole bunch of requirements about how artificial intelligence-based systems are to be regulated to try and ensure against bias, to protect against any potential abuse of human rights, but perhaps most importantly, to make sure that the AI tools are as transparent as possible so that people who are using, the clinicians particularly who are using those systems, can have a good assessment about whether or not the particular AI-based solution they're using is actually appropriate for the patient or the patient group they are seeking to serve. Now, it would be lovely to say, okay, the AI Act says that AI algorithms must be transparent, and that's fine because now doctors will know exactly what they're using. Doctors have studied medicine; they haven't studied data science, and even if they had studied data science, the chances of them keeping up with that science, which is developing so quickly whilst practicing medicine, is very remote. So we will have a disconnect. The science, data science will develop, and saying that an algorithm has to be transparent is slightly of a sticking plaster approach because it's not going to be possible to make it truly transparent so that anybody can understand it. But I think building into the legislation an awareness that there is a risk of potential bias and making sure that the providers of systems based on AI have as much as possible shown where those potential biases exist and support a clinician in our setting, in a healthcare setting, of understanding what that potential bias is so that a clinician can choose not to use a particular algorithmic tool in a particular setting is some way towards getting there. So part of the solution is legislation, but I'd say the other big part of the solution is recognizing that data science is hugely under-resourced with human resources. We just don't have the data scientists to actually develop the nuanced tools we need at the moment. So it is up to countries to really support and invest in the development of data scientists and specialized healthcare data scientists. And I think with those two working hand in hand, more data sciences and finer grained legislation, we can begin to overcome some of those challenges.
Thank you. I could see both Ratna and Professor Martin Cowie were nodding at different points as Petra was speaking. So maybe I could invite you both to come in on this issue of how do we make sure that the technology we develop is based on diverse users, is culturally appropriate, it works for the population and the patient groups that it's going to deal with. So Professor Martin Cowie, would you like to respond to that first, and then Dr. Ratna, I'll come to you.
Yes, and I agree with 99% of what Petra said there, but I think it's important to realize that these biases have been with us forever. For example, the Framingham Heart Score that we used for 20 years in cardiovascular disease was based on a very small population in one state of USA of largely Italian extraction and mostly men. And that was used to predict risk for everybody for 20 years. Now we've got more nuanced than that, but the AI just makes it more of a problem because some of the methods are even less transparent. But I think the vision of the future is you've got a patient in front of you, you're trying to advise them, you're trying to personalize both the prediction of risk in front of them and what their treatment options are. You're trying to blend that with their values, what's important to them, and coming up with a solution that they're comfortable with. That's the art of medicine. Now, risk prediction algorithms are part of that, but they're only part of that equation. I'd like to see a future where we actually use real world data from the population that patient and doctor are from, saying, we know in our country, somebody like you, these are the factors that will help identify the future risk. And that then is really personalized, culturally appropriate, etc. We're away from that. So to Petra's point, we need this process of dialogue between data scientists, between healthcare systems and medical records, between patient groups and physicians, how can we ultimately arrive at with more personalized, more appropriate advice and better outcomes and experience? That's the challenge. I think we realize the issues and we're slowly feeling our way forward in them.
Thank you. Ratno, can you share perspective from the international patient networks?
I sort of agree with what both Petra said and what Professor Covey said. You know, these disparities have been there forever. If you see how medicines are tested, you know, in low and middle income countries, you hardly have any patients participating in clinical trials. Yet we use these medicines using the data that is coming from the Western world or from the more developed countries where these clinical trials are happening. And that over time has changed as people have started to realize that, you know, certain populations don't respond in the same way as the populations that responded to when the trial happened. And with this realization, there have been revision of guidelines, you know, whether it is physical activity or obesity or measurement of diabetes indicators, etc. So I'm guessing that this is just a beginning. As the explosion of AI and use of data happens, there will be realization that different populations have different ways that they will respond to certain techniques and technologies. And therefore, the doctors will have to then be practical and use it based on their personal experiences, because at the end of the day, the doctor uses a lot of clinical acumen that comes from experience of dealing with patients who are local populations to use the judgment to come into a proper diagnosis. It's not always, you know, what is taught as a differential diagnosis. You are using your clinical acumen. So I think the same thing will play here as well. While AI will continue to progress and there will be a lot of use of data to drive decision making, I think physicians who are treating patients will be actually looking at the patient themselves, hearing what the patient is telling them about the experiences of, how they have responded to certain drugs and devices, etc., and then base the judgment based on that. And it will be more personalized as we move forward.
Thank you. Petra, we've got a couple of questions, I think, that have come from the audience that I think fall nicely on your desk. We've got this issue coming up. You know, somebody says, given the lack of regulation, is there a risk our heart health data could be used against us in terms of health or life insurance? So here we've got this issue of trust. And somebody's also said, you know, currently in some places, it's often the case that patients need written permission to read their own health files. What are your thoughts on that? I think those two land on your desk.
Thank you. So the first one about the written permission to read a health file. I'm not an expert on law around the world. I can tell you that at European level and in most countries in geographical Europe, that is not the case. Patients have a right to see their data. There is in almost all countries a small caveat on that, which is that if a physician believes that it would be detrimental to a patient's health, usually mental health, to see their full file, it would be possible to withhold part or all of the file. But that's an exception. Generally speaking, patients are entitled to see their data. Now, one of the problems here that arises is a practical issue. When we used to have a physical paper file that you could take a photocopy of or even just pass to a patient to look over, it was a different situation. Now an awful lot of data is held electronically, and it's not simple and straightforward there and then in a consultation with the patient to give them access to their file. It may take a little while. There may be a procedure to go through. And it's important that there's a procedure to go through, because whilst we want a patient to have access to their file, we also want a proper audit trail. We want to see who has accessed a file, when and for what purpose, so that if a patient feels at some point that their data has been accessed inappropriately, that could be demonstrated. And the physician or the healthcare system can defend themselves, saying that, you know, we followed a procedure and we know exactly who accessed your record, when and where. So the first question about written permission needed to access a file, I'm sure that's the case in some places in the world. I think it is becoming less and less the case. And as patients' organisations, I think it's really important to work against anything like that and help patients really get access to their data. The second question about whether or not data could be misused against an individual, I'm guessing this goes towards the issue about insurance and how some people may be denied insurance. It's a really difficult issue because an insurance provider has to mitigate against risk. An insurance provider has to be able to be financially viable. So it is important that some people's risk can be properly assessed by an insurer. Does that mean that they should be excluded from care? No, it certainly doesn't. But to come again with a sort of blanket ban saying health data can never be used in order to stratify the risk of a patient, I think is naive, because it denies the reality, the financial reality within which healthcare has to operate. Both of these issues, however, of access to medical records and appropriate use of data, is the sort of area in which we really need to work to ensure that the legislation is appropriate and usable. The GDPR is not a solution to everything, but it is a good step in the right direction. It has many problems, but it does have at its center that notion that an individual has a right to access data that is about them. And also that if you use data and you access data, you must be able to demonstrate that you had a good reason for doing so and that you used it in an appropriate way. And with both those elements, one can begin to address some of the challenges that I think are inherent in the question that you've put to me, Tamsin. Thank you.
Excellent. Thank you. Very, very interesting. I think our audience will find that very useful. Professor Cowie, let me come back to some of the questions again we're getting in the chat. And you spoke about how one of the ways to deal with the different biases is that a doctor or clinician should be able to choose and identify an appropriate AI-derived tool to use with that patient because it has the appropriate background. And that assumes this wonderful smorgasbord of choice in these things. But we've got someone in our questions who's raised the fact that actually it's the big tech companies that are increasingly moving into healthcare. And this is the Amazons, the Googles, the Apples of this world, the Facebooks, and these people don't play nicely with everyone else. They're in it for world domination, let's be very clear. And we've just had a very sharp lesson in this when various countries tried to roll out their own test and trace contact app for COVID. And we're told very brusquely by the people who control the mobile phone operating system, that's Apple and Google, no, your app doesn't belong on our place. So what is your view about, the increasing interest and investment and power of the big tech companies to create they own the operating system software within which you as a clinician or a patient have to operate. It's their playground. They set the rules, they hold the keys. So perhaps I'm painting too negative a picture. How do you view these things?
Yes, I'm not sure I'm the best person to answer such a global issue. And of course, it's very multi-layered, isn't it? But, and most of us have absolutely no understanding of who accesses our data on the apps and where they go and whether we've given permission and how long it's there, to be honest. I think as a physician, though, I never expect a tool to be anything more than a tool. So if somebody comes to see me and says, should I take a statin? I say, well, why are you asking me the question? What's the background? Why are you interested? Let's think about your family history. Let's think about your genes. Let's think about your lifestyle, etc. And then they'll say to me, but is it worth it? And I'll say, well, that's an interesting question. So let's try and visualize why it might be worth it for you. And then I would use a risk score. Now, because I work in the UK, I would use QRisk3, which is based on huge general practice data set in the UK. Now, it's not fantastic. It's still only right 7 times out of 10, but it's better than guessing or me just thinking of a number. So I'd say roughly this is the risk. Now, let me explain this. And I show visually Gantt charts to show them how exactly that might work out, how many people would take it, who would benefit, etc. You then have a discussion as much as they want to have a discussion about it, and you sense where that discussion is going. So it's a long-winded way of saying that it's not just about tech, it's not just about data points. It's about thinking, what are we trying to achieve? What's the discussion point? What matters? And what's my role as a physician? I think you're right about the big tech companies. I'm not sure how it will play out. It seems to me that you have to be world dominating to move things forward, and then you create a new world. Look at Apple. Initially it's a fashion thing, and now it's all about tech and medical diagnosis. How is that going to play out? I don't know, but I do know that we as patients, patient advocates, as physicians are absolutely legitimate stakeholders in this discussion. And where people get it wrong, we need to call it out. So last thing I'll say before handing over to Ratna is look how DeepMind, IBM, I believe, got it wrong working with the Royal Free Hospital in London. They took all of that data set. They were developing with the physicians there a tool to predict development of kidney problems when patients came into hospital. Hugely important for patients. You would have thought that society would be accepting of that. It's anonymized data, it's used for a good purpose, but it's not. And in fact, there are 2 court cases, I believe, at the moment, challenging why the data was used for that purpose without people's knowledge. That's really interesting, isn't it? So I would bounce it away from the physicians back to society and say, what do you want to happen? What are you happy with? What are you not happy with? And let's have the conversation. Sorry, a long-winded answer to say I don't know.
I think nobody has a full crystal ball, but I think it's useful to know that, everyone involved in healthcare has a clarity of vision about where their role is. And as you said, the legitimacy of doctors and patients are being key stakeholders and, having a leadership function rather than just the passive recipients of technology. Ratna, would you like to come in on this? Because I saw you nodding several times.
Yeah, thank you. And nobody has an answer to this question. It's a scary world out there. And if you see patients or any one of us, we really don't know what information we are putting into which app and how that is going to be used. And health is one part of it, but you also see people putting in banking details in all kinds of, very questionable sites and then getting scammed about it. Whereas people are very possessive about the money that they earn, not so much possessive about their healthcare or not so aware about their healthcare. But we do know that every single person on this universe doesn't want to lose the money that they have earned, yet they do very stupid things just because they are not aware or they didn't think that, what they were doing was not the right thing to do. And whatever awareness you might bring amongst people and general populations, these kind of things are here to stay. And I think it's a question of bringing in stronger regulation and stronger legislation to be able to overcome these challenges. Because as you said, it's their playground, they hold the keys. And how can patients, however united we might be able to bring any change in that? It's not going to be possible. So it has to be more governments and other bodies working on how to bring about more transparency in how this data is being used. But I would like to briefly respond to what Petra said about, people having the right to own their data and to be not own. I will not use that word, to be able to access their data. So in countries like, say, India or many of the Southeast Asia countries and Africa countries, a lot of healthcare is out of pocket. Where the hospital has the data. And even if you have a right, meaning your country's legislation says that you have a right to be able to look at your healthcare records, the hospitals will almost never give you the full picture. They will only give you a summary. Because A, they don't want you to see what you have been billed for, because some of it is not very transparent and honest. And B, they are scared of litigation because obviously, they're not following the norms that have been set for by the country. So even if you are a very influential patient organization or you have the access to people who you can request this information for, most often you don't get the healthcare, records that you ask for. You only get the summary information. And this creates problems because you have mixed systems of healthcare here where half of it is electronic and half of it is paper-based. So a lot of times patient actually lose the whole data trail, and they have to start all over again, including doing all their blood workouts and all their diagnostic checkups all over again because they didn't get that information from the previous hospital. So I think we have a lot more work to do in that area as well.
Petra, do you want to make a comment on this?
Yeah, just very quickly. I think there's two things there. Firstly, the people having to do their work again, blood work and stuff like that. There is a historical element here as well, which is that many doctors are still trained not to trust data coming from somewhere else. There is still a training that you touch the patient, you get your own data, you collect your own data. In order to accept somebody else's blood results, you need a trustworthy system, somebody else's lab results, actually. You need a trustworthy system, you need a standardized system, you need interoperable systems. So I think there is that element. There is a technical element that has to be addressed. And then there is also the human element of whether or not a person can actually easily get access to their data. And, even in a country like the United Kingdom, England has had Access to Medical Records Act since 1990. Just last week, I was acting for a patient and helped the patient ask for their record in the hospital as an oncology patient who was facing some problems. The answer the patient got was, "Oh, you don't need your act. You don't need your medical record. Just ask me what you want to know and I'll tell you." Now, that may have been the physician being helpful, saying that actually getting all the lab results and everything is probably not going to give you the answer that you want. But it could have also been for other reasons. And I think what was really important there was the person who I was acting for was a reasonably well-educated, able person who came to me and said, "Oh, I've been told I'm not allowed to get my records." And if that happens in a country like England, which has had legislation in this area for very many years, since 1990, we have a long way to go in other places in the world still.
Thank you. This brings me to the final point I'd like you all to give me very briefly. One piece of advice that you would give to patient organizations like the members of the Global Heart Hub on how to prepare themselves to deal with the technology changes in cardiovascular care and management. So, Professor Cowie, can I invite you to do that? And each of you, short 30 seconds, what's the advice you'd give patient organizations?
I'd say that you are very, very much the legitimate stakeholder in this process. It's not something that should be done to you. It's something that we should be co-designing for the future. I think there's lots of exciting potential. There are some challenges, but let's be honest and adult about it. Put them on the table, discuss them together. That would be my tip.
Excellent. Thank you. Dr. Ratner.
I would say that, patients are not somebody out there across the horizon. They are all of us. Many of us who are clinicians are also patients. And therefore, we need to be more inclusive and try and get these experts who are also patients to share their views and be part of the community. So right now, there is a divide. There is this patient organization and healthcare providers, and then the legislators and the regulators, etc. I think all of us are patients, and especially for cardiovascular and diabetes, which is like an explosion in the world. You find it in every house. How do we become more inclusive and call ourselves part of the community and share our experiences to make it a better experience for everyone?
Thank you. Petra.
So I fully endorse what Professor Cowie and Dr. Devi have said. Co-creation is the answer. However, co-creation doesn't come for nothing. So I would say the biggest piece of advice I would give is lobby hard to get the funding to be able to really engage patients in co-creation, because otherwise you will end up with a bias of those patient groups who are able to do it out of their own pockets and have the time to do it. We need funding to do proper co-creation.
Thank you. And thank you to our panelists, to Professor Cowie, to Dr. Ratna Deviv, to Petra Wilson, and to Jean-Luc, who had to leave us, unfortunately. Thank you for sharing your insights and dealing with our amazing questions that came from the audience. We had lots that we didn't have time to get through to. But let me go back to the poll. Right at the beginning, we asked people, do you think technology should have a greater part of cardiovascular care? And if you remember at the beginning, it was very heavily yes. And now I'm seeing with, some of the issues that we've brought up, the challenges, the gaps, the legal uncertainty, the biases, I think we've shifted the needle a little bit. And people are saying, we've got a few more people saying, maybe. So I think that's an interesting point. And we've certainly come up with some ideas for patient advocacy to take forward. So a warm thank you to you for having participated in this panel, and to you, the audience, for sharing your ideas, your questions, and your concerns. Let me close this panel now, and I'd like to pass the floor back to Neil Johnson, the Executive Director for the Global Heart Hub, to just summarize how we've been today and yesterday.